Hi there, I'm Dr. Stephen Fallon. Welcome to Dental Excellence. This is Dental Excellence video 19. I've shot quite a few of these now, and if you've watched all of my Dental Excellence videos, I'd like to thank you for your support. We've had a couple 100,000 views of these videos on the various platforms I'm hosting them on, and that's really awesome. It's kind of humbling to think a few 100,000 views of my videos have been out there. The Dental Excellence series, I've had probably 1 million video views of all my videos, or probably more than 1 million if I added it all up on the different platforms. But the Dental Excellence series has been very popular because of all of your support. Now, if this is your first video with me, I'd encourage you to go back and watch the other 18 Dental Excellence videos. Each video is fairly short, they're 5 to 15 minutes long, and they each have one important teaching point. That's the goal of each Dental Excellence video. Sometimes they have more than one point, but I try to create each video with one really important teaching point and one theme. So this video is what I call Dental Implant Adventures. Dental Implant Adventures. And this week, Tuesday, Wednesday, I was working on a partial mouth rehabilitation, almost a full mouth rehabilitation, but I would say a partial rehabilitation. And on the Wednesday, I was prepping the upper arch. So we were prepping most of the upper arch. We had one tooth that was removed last month and was grafted, a first upper molar. So it needs more time before we're going to work on it. So it's basically going to be delayed till next year. So because we have to let the socket grafting heal. So that particular area is not being treated right away. But the rest of the arch is being treated, and there happens to be one dental implant. So the way I thought about kind of staging the treatment here is I was going to prep all the teeth first by quadrant, kind of half at one point and half at the other point, just because of fitting the rubber dam and getting the rubber dam to stay seated properly. I thought I'd do it one half at a time, plus managing local anesthetic. So each tooth in the arch needed old restorations to be removed, and I placed core buildups. So each tooth had a new core buildup. But the one tooth with the dental implant, it had a Straumann RC bone level implant, which is cool because that happens to be what we mostly use. So I'm the most familiar with that implant from a prosthetic point of view. So I felt it would be not a big deal. I would just unscrew this. It was a screw retained implant crown. I would unscrew this right before taking the final impression. And the reason I left the crown there is I wasn't sure how the healing abutment would fit on the tissue outline profile from the crown. So what I wanted to do is prevent debris from all of this preparation, removing the old restorations, cleaning out the decay, placing core buildups, packing retraction cord. I wanted to prevent debris from going down and sitting around the implant tissue interface and on the platform, and maybe getting even between the implant and the tissue. So I wanted to keep that whole area clean, and the best way I felt was to leave the old implant crown in place, and then right before the impression I'd unscrew it, place the implant impression transfer, and take the impression. So we got to this point. I took the picture even, and then I asked my assistant for the driver, the implant driver, and I tried to unscrew it, and it was pretty stuck. So, typically you have to use the torque wrench. That's no big deal. So I was using the torque wrench, and it wasn't, it was up to 25 newtons, and it wasn't budging. So I torqued it all the way to, must have been high 30s, and I felt it give, so that's good. So it started to turn, but it didn't feel normal. And so I turned it some more, and I started turning it. And usually once you've turned it about one revolution, maybe two revolutions, the implant crown is loose. But the implant crown wasn't loose at all. and it wasn't turning normally, the screw inside the screw retained implant crown. And when I took out the composite resin, it was quite a bit of composite resin in the access hole. And the cotton pellet, there was a cotton pellet underneath, and it was pretty damaged looking, meaning it was infiltrated with resin. It didn't look good. So I thought to myself, well, this isn't good. And I use at this point I've switched all day prepping this arch between my microscope and my loops with my LED light. And I had my 4.5 times magnification Zeiss loops with the LED light, and I was looking in there, and my light had just died, and I just couldn't see in there very well. So I had to pull the microscope over and take a good look in there. And this is what I saw. I'll show you the video. So here we are. You can see right there. I don't know if you can see very well. Doesn't look so good. There's all kinds of debris on top of the screw head. And when I looked closely, what I realized was the perimeter of the head of the screw was covered in either flowable composite or filled adhesive, because usually you would look in there and there's a gap between the head of the screw and the implant supported crown, and it's nice and clean, and you can unscrew that and it comes up. And the problem I believe I was having was the screw was rotating, but it wasn't disengaging. It wasn't moving vertically because it was locked into some composite resin. So it was a bit of a mess. And even with my light working on the loops, I don't believe I could have seen as well in there as with my microscope. So instead of, as I said, my light had just died, instead of going and getting a different battery pack, I pulled out the microscope because it was right there. And I'll show you the rest of the video. You can kind of see, it's a little shaky because I'm trying to move the mirror around to see what's going on. And I'm using a probe. So I tried a periodontal probe to pick it away, and it broke my periodontal probe. So I had to switch to an Endo Explorer because that's finer. If you notice, there's a gauze throat pack in the patient's throat, because from my experience, anytime I'm working with small implant parts, I like to have a throat pack there in case something drops. Now, if you take a look here, here's with is that the probe still? That's the probe still that was broken. So I couldn't get in there with the probe. Sorry, it's a little shaky just because of the way, oh, there, we can almost see it. I was trying to get to the point where you could see it in the video. So if you look, you can see kind of all the composite around the head of the screw. And it's just everywhere around the top of the screw and in between the wall of the implant supported crown and the head of the screw. So this is why it wouldn't come out. You can see there I'm picking at it. I'm with a Endo Explorer now. It's about the only thing I could get in there with. And I'm trying to just pick away the adhesive or flowable composite from the implant screw. So you can kind of see it really well right there. So right there, I'm trying to get in with this Endo Explorer. It's actually bent at the tip from working away at this. And the actual bend gave me a little hook. And the hook actually, the tip bent a little. I had a hook. It actually made it easier to pull out the composite resin. So you can see there I'm pulling it out. And I've got most of it out there, but I still had to work some more. And the bottom line was, even with a lot of magnification, this was difficult. As I said, I use 4.5 times Zeiss loops, which are over here, with a LED light. But I had to switch to my Zeiss Pro Ergo microscope because I just couldn't see well enough in there, and I had to pick out manually all that composite resin or adhesive resin around the screw head of the implant. Screw retained implant crown. So the bottom line for this is I think you have to be careful filling these in because, I believe right now screw retained implant supported crowns, especially in the posterior, are more popular than cemented because of the excess cement problem and peri-implantitis problem. So screw retained crowns have kind of switched to being the more popular crown. But if you put a little cotton pellet, this had a small cotton pellet, and you pack, say, adhesive resin or some kind of bonding agent, the cotton pellet is permeable to that. And it gets all over, again, the screw head. And if it light cures, you get what I had. So the solution that I have used for years that's solved this potential problem is I pack the access hole with plumber's tape or Teflon tape. It seems more permeable. It seems less permeable to the adhesive resin if you want to even use that, and it can create a very nice barrier between the head of the screw and whatever composite resin you want to put on top to close the access hole. So we put, actually, if you looked at the height of the screw or the height of the crown above the screw, we probably fill that 3/4, minimum half, to probably maximum 3/4 with plumber's tape or Teflon tape. So we roll up a pretty long piece, we make it kind of a vertical cylinder, and I pack it in with a composite plugger. And that provides me with and because you could really condense the plumber's tape, it gives me a very nice seal. And then I could just put composite resin over top of that, and it doesn't get down to the head of the screw. So plumber's tape instead of cotton pellets, I think it's really a good strategy. So no more cotton pellets to seal the access of a screw retained implant crown. I think that's a weak strategy. I think Teflon tape's a much stronger strategy. And I've had to take a couple of these out here and there. And I'll tell you, when I screw out the composite resin, because I use this with provisionals too. So with provisionals, you get to really see, because I'm taking them on and off as I'm changing the profile of the tissue, so that you take off the unscrew the, or drill out the composite resin with these provisionals. And I go to pull out the plumber's tape, and it doesn't look like this infiltrated mess that the cotton pellets look like. It looks pristine. So it's a better seal, is basically the bottom line I'm trying to get to there, than a cotton pellet. So I think Teflon tape is really the way to go. And if you look, I drew a little picture with my iPad to show you. Now this is kind of messed up because the screw's not down all the way. It's actually, don't know why I drew it like that. But here's the idea anyway. The screw has Teflon tape on top of it. If you imagine the platform was here. So it's kind of a funny drawing now that I look at it in my slide. But the idea is good. So you've got the head of the screw here. You have a big barrier of Teflon tape. And then you have the composite resin on top. And you may ask yourself, well, am I using adhesive resin? And I'll be honest with you, I don't. I just put, basically, for most of the cases, I put a opacious dented composite resin over the plumber's tape. And it's about half to 3/4 plumber's tape, 1/3 to 1/2 composite resin. No adhesive, because again, I'm worried the adhesive is going to get down, light cure around the screw head, and we'd have this problem. If you want to get fancy, and I'll tell you, I think the only reason to get fancy is for occlusal photos of your case, because the patient's not going to see whether or not you have a fancy composite resin in there or just an opacious composite resin in there, because the access hole is small and it's in a back posterior tooth typically. But if you want to get fancy, you can put a barrier of the opacious composite resin, and then you can even micro etch. You can silinate the porcelain perimeter. You could put the adhesive resin in, and then you could put even a more aesthetic composite, even some tint, some little brown tint. And so you can get fancy like this. But I wouldn't get fancy until I have my plumber's tape plus a layer of opacious composite resin, light cured, like filled composite resin, not flowable, a layer of filled opacious composite resin on top of the plumber's tape to create a really powerful barrier from getting anything down onto the screw head and having problems like I showed you. So at that point, you can get real fancy. You can, perimeter etch with porcelain etch. You can micro etch. You could silane the perimeter porcelain. You could put adhesive resin. You could make it as pretty as you'd like. But really, the only reason you're doing that is for photographs. The patient's not going to notice likely one way or the other because it's such a small little hole in the center of the implant supported crown. And sometimes trying to get fancy, they end up lowering value and looking less fancy. But these are things to consider. Again, this drawing's a little flawed. After drawing it and putting it on my slide, I realized I should have had the head of the screw down here. I don't know why I did that. It's like the screw's not screwed down. But no big deal. It's the bottom line is the point of what I was trying to show. And I think that's the important thing. So I drew that on my iPad Pro with the Apple Pencil. It's kind of fun to do. I enjoy drawing on that once in a while. So this is Dental Excellence 19. I hope you like the tip. That's the most important teaching point. Today, the teaching point is don't use cotton pellets in your screw retained implant crowns and provisional crowns. Use Teflon tape. It's a great barrier in these cases. And I believe it can seal the access better than cotton pellet by a big margin. So this is Dental Excellence. I'm Dr. Stephen Phelan. Remember, you can do this kind of dentistry. I believe that beautiful dentistry with precise fit and occlusion is not just for the gurus. So thank you, and we'll talk to you soon. Take care.